So here's a review on hypertension in pregnancy according to the ALARM course in the context of working in Angava. So in terms of the diagnosis of hypertension, as you know, systolic over 140 or diastolic over 90, and that's based on at least two measurements greater than 15 minutes apart. And you want to give the woman a chance to settle in, rest, not that she's just run into the appointment or has just been out for a cigarette. I noticed in the OSFQ medication guide, it talks about 2 hours apart is the blood pressure reading. So that's something else to look up. In terms of severe hypertension, the number that's key where her risk of stroke increases. So she risks blowing a blood vessel in her brain over 160. And also just to be aware that everyone's different. So you know, a woman may have a lower threshold of stroke, or another woman may have a higher threshold of stroke with different systolic values. So not everyone is the same, but we do know that we want to use medication in the case of severe hypertension to lower her systolic below 160 in order to immediately reduce her risk of stroke. So there's two things that are happening with hypertension, and the way I explain it to women is that when the first thing is when their placenta was built at the beginning of the pregnancy, there's constrictions where the blood flows, and so as the pregnancy progresses, as the baby gets bigger, her blood pressure has to increase in order to push the blood through to the baby. And it's just the way the placenta was built. We don't know all the details of why it's happened to her. It's nothing that she's done to cause this. It's probably a combination of genetics and immunity, how her body responds to being pregnant the first time, if it is the first time. So with that said, she's got this placenta that kind of is considered constricted, and so her blood pressures increase in order to push blood to the baby. And so the second thing that can happen to her, and the way I explain it, is that we're concerned that her blood pressure is high and it's pummeling or beating up other parts of her body that are fragile. So her brain, eyes, lungs, brain, eyes, liver, and kidneys are the big ones that I think of. But, you could also have, there could also be symptoms like chest pain or high reflexes, something affecting her nervous system, as well as there could be a problem with clotting as well. So basically, I explained to her it's nothing she's done. It's the way her placenta was built. I blame the placenta. And I said we want to bring down the blood pressure just enough so her body doesn't get hurt, but keep it high enough that the baby can still be well oxygenated and fed and grow. So in my initial assessment, I got this blood pressure reading. So I'm going to do a complete assessment. So say she came in for a routine assessment and I have a high blood pressure, I'm going to add a bunch of things in this assessment right away. Or say she comes in with a concern and I'm assessing her, I do her blood pressure, and it's high. So I'm going to do a complete set of vitals and include an O2 sat. And if it's under 93, it's ominous. So she should be 95 and over. Do an NST. If ultrasound is available, I'm asking for fetal growth and amniotic fluid volume. And if there's a concern with either of those, you add in a Doppler. And then I'm going to do labs. So I'm going to do a complete blood count. So I'm looking at specifically her hemoglobin and platelets. I'm going to do liver function, and I'm specifically looking at the transaminase liver enzymes. So is her liver getting hurt, that it's spilling liver enzymes into her blood? Are her kidneys getting hurt, that she's spilling protein? And so we do a spot urinaire, and that one is a calculation that if she's over 30, it's at just proteinuria. And it kind of is an estimate of the old 24-hour urine that hopefully we will never go back to. And once she's labeled as positive for proteinuria, you don't need to repeat the urine anymore. So any sort of increase in proteinuria is an indication of anything. So it's just like once it's over and she's over 30, she's protein positive, and now you're going to count her as hypertensive with proteinuria, and I'll talk about more of that later. And then also we're going to look at clotting, and that's a PT. I believe her clotting time increases, is what I understand. And then because we might be thinking about her having a baby sooner in order to keep her safe and the baby safe, we would do a GBS swab because we're thinking she might deliver sooner. So let's say we call her gestational hypertension. All her blood work was normal. She's negative protein. So we're looking at, and the spelling mistake I just want to point out was in the alarm course. It wasn't something that I added. We want to think about how to monitor. So let's say she's 30 weeks. She has high or high-ish blood pressure, not requiring any medication. But we're kind of talking about, so we're talking about increased monitoring, and we're going to start talking about a plan for early transfer to Montreal. So we can organize a blood pressure cuff for her to be doing her blood pressure cuff, her blood pressure readings at home. And then we could have her come in once a week, and she'd be having her blood pressure checked by us, checking for proteinuria, fetal assessment, NST, add in ultrasound if we have it. The ultrasound is looking specifically at growth and amniotic fluid volume. And then also with patient teaching, we're doing fetal movement counting and reviewing signs and symptoms of preeclampsia, which are headache, vision, blurred vision, stars, epigastric pain, upper right quadrant specifically, new onset of vomiting, and new bruising, sorry. So in any case, in third trimester, new onset of vomiting should be assessed, and you want to rule out preeclampsia as like be highly suspicious of that. Also, I would add, because we can't do fluid assessments on a regular basis, say a weekly basis, she also has the option to transfer to Montreal if she wants earlier in order to have closer monitoring. So we can do a bit here, but the one thing we would be missing is weekly amniotic fluid volume assessment, according to the alarm. And this is just a minimum. This is your minimum. It's a weekly follow-up for someone with hypertension, not a medication. So if she's on medication, so meaning her blood pressure is over 160 or over 110 diastolic, then there's a maintenance medication, an antihypertensive medication that could be started. And again, you're trying to reduce her risk of stroke by bringing her blood pressure into that zone of, say, 130/55, and again, 80/105. So we don't want to bring her blood pressure back to where it was when she got pregnant, because that won't be enough to sustain the baby. So we just want to keep the blood pressure in a zone that will prevent or lower her risk of stroke. So let's say after a consult, you decide that she doesn't have proteinuria, she can be on antihypertensive medications, and we're going to do our assessment for her in the community. So she comes in once a week into the community or twice a week. So we've got her blood pressure maintained in this zone here, and we're doing our fetal surveillance, and we're reviewing her risk of preeclampsia. So here is a maintenance therapy. So for example, starting with labetalol, and this would be an example, 100 milligrams PO BID to a max of 400 TID. So the idea is you're trying to control, you're titrating the medication, or the doctor is titrating the medication to get this stable blood pressure. So those are some options to have in discussion with the doctor or consulting doctor. Okay, so this is the woman I'm talking about. She has gestational hypertension, She's doing home monitoring that we can organize with a blood pressure cuff at home. And minimum, she's coming in to see us once a week. And we're testing her spot urinaire for protein in her urine. We're reviewing signs and symptoms of preeclampsia. And we're doing, we can do weekly, well, here they do proteinuria. If there's proteinuria, we do a panel, eclampsia panel. But I would say you should have at least a baseline preeclampsia panel once you've decided she's gestational hypertension. An NST minimum once a week, and then organized ultrasound. We could do growth and amniotic fluid volume every 2 weeks if there's an alternating abdominal obstetric ultrasound technician in town every 2 weeks. Otherwise, it's every 4 weeks. And again, you can offer her Montreal transfer earlier if she'd like closer monitoring. Okay. So keep in mind, for timing of delivery for gestational hypertension, it's about 37, 38 weeks. So this woman, we're getting ready to transfer her down south. And if you've worked on the Hudson Coast or you know people on the Hudson Coast, you may know that sometimes they'll keep people with gestational hypertension or even preeclampsia and do inductions there. I think that is incredibly naive, and I wouldn't recommend it because hypertension is unpredictable. We don't know always who is going to have a stroke or who will start convulsions and who will need emergency delivery. And, that a couple things like in Montreal, she would have closer surveillance with biophysical profile, amniotic fluid volume, and growth. And should urgent delivery happen because of her increased risk of abruption, for example, or intrauterine growth retardation or restriction, that quicker delivery is accessible in Montreal. So just thinking of the gestational hypertension case, so like say she doesn't have proteinuria, she just has hypertension, she's well managed on medication, she can transfer down to Montreal on the scheduled flight, at 36 weeks. In the case where she has preeclampsia, we're making a plan sooner because she already has proteinuria. She could be going down south. She does need closer monitoring. So let's say we have an acute hypertension assessment. So this is someone who never had any sort of previous concerns in the pregnancy, or, baby blood pressure was a bit labile. She comes in with very high blood pressure, protein in her urine, and perhaps symptoms are included. So any of those symptoms like headache, blurred vision, upper right quadrant pain, perhaps her O2 sats are lower, she's not putting out a lot of urine, or she's spilling protein. So you just want to, we'll have orders for this soon. So the group are working on, Alexander Vivier is working on a order where in sort of one stop, without needing to call the obstetrician down south, we can just get a set of, get the woman stabilized. And so your first step is to bring down her blood pressure. So let's say she comes in with a blood pressure of 210/180 and with symptoms, and you're starting all your lab work, but immediately you're calling the doctor to come, and we're going to together bring down her blood pressure using medication because we want to prevent a stroke. We're going to start magnesium sulfate, and that prevents convulsions. We're going to start continuous monitoring. We're going to do fluid restriction and start a catheter, and we're going to monitor input and output. So don't bolus this woman. Her risk of pulmonary edema is quite high. And the catheter is the 350 ml catheter, urinary catheter bag that you're going to very closely monitor her urine output. And anything under 30 is considered 30 milliliters an hour is considered oliguria. And that needs to be managed carefully. She's more at risk if she's on magnesium sulfate of magnesium toxicity if her kidneys aren't working that well. When they talk about symptomatic support, this is something I often forget, but basically you want everything kind of quiet, low stimulation, nobody getting too excited. And you know, it used to be like a dark room, but keeping everything calm, and then also with pain management. So let's say she's starting to have any sort of contractions or the pain around dealing with either the headache or the upper right quadrant pain. You want to manage the pain because the pain makes the blood pressure go up as well. Okay, so for the severe hypertensive case, we're just going to aim to bring her blood pressure down. Sort of anything under, 150 would be nice, and anything under 110 diastolic would be great. And you don't want to drop her blood pressure too quickly. And so you could do labetalol, 20 milligram IV, for example, or nifedipine, 10 milligrams swallowed, not chewed. Double check that the nifedipine isn't the XL. That's for the slow. That's the slow release for someone who has gestational hypertension, and we're not. It's in the lower category. But nifedipine acute, you want the regular one, not the XL, and you're going to start with 10 milligrams swallowed. So say you've got an acute case, like the one we just talked about, quite severe. Go for labetalol IV, and you've got a peak on. You want an onset in 5 minutes, and it's peaking in 30 minutes. So you've got her being monitored. You're arranging, say, a challenger. So she has her medication for her blood pressure. You're trying to bring the blood pressure down. You have magnesium sulfate to prevent the convulsions. You've got a Foley in, continuous fetal monitoring. Those are your four things. So blood pressure meds, magnesium sulfate, continuous fetal monitoring, Foley catheter. So 2 things can happen that are of concern. So one is an eclemtic seizure. So a seizure where, she may become disoriented initially. She may start with short spastic movements, or she may have a full clonic seizure. And so the idea for that is to keep on monitoring and just keep her safe so she doesn't fall off the bed, so she doesn't hit herself. But you can do a bolus of magnesium sulfate, 4 grams over 20 minutes. And so before we started the magnesium sulfate, it was 4 grams over 20 minutes, and then we reduced it to 1 gram an hour IV. But now that she's had this seizure, you can do another bolus of 4 grams, and maybe the following, after you finish that bolus, you may start it at 2 grams an hour. So with the doctor down south, you'll be having that discussion. In the case of magnesium sulfate toxicity, what happens is the woman, and I've never had one of these cases before, but what happens is the woman goes unconscious. So what we're doing while she's on magnesium sulfate is we're doing a close monitoring. And so a couple things. So respiratory rate is over 12. She has normal reflexes, not diminished. So her baseline reflexes compared to now that she's on the magnesium sulfate should stay about the same. And like I said, so her urine output, if it's under 30 mils per hour, she's more at risk of magnesium's toxicity because her urine isn't her kidneys aren't putting out fluid. So that looks like someone just going unconscious. And so you stop the magnesium infusion, you start respiratory support, and then you give calcium gluconate, 10 mils in IV over a 3-minute period. So there's some lab work that can be done that can just double check what it is. But the idea is a young, healthy woman who's in Kuujjuaq, who shows up with an acute case, probably won't develop magnesium sulfate toxicity because she hasn't been sick for a long time. Her kidneys are just starting to take the big hit. And so hopefully all those other women, anyone who's at risk of this because of poorly functioning kidneys, because they're on magnesium sulfate for a long time, they're not with us. They've already gone down south. So in terms of postpartum management, usually the doctor will recommend, it could be that they're on antihypertensives for 3 months. It could be that more lab work is done. The magnesium sulfate, they would just discontinue it in the postpartum period before sending her back to us. They also might put her on a diuretic. So I think it's called furosemide. So it's a diuretic, and what it means is if you're on a diuretic, it makes you a bit hypovolemic or less blood volume, and so you can use less diuretic, less antihypertensives for them. So combined together, a diuretic and a hypertensive, they can be on a bit lower dose of antihypertensives. And then also just to talk to her about optimizing her health in the future, close BP monitoring, and tell her that when she gets pregnant to come into care early, because we can maybe start on aspirin. So a doctor can prescribe aspirin. We use 162 milligrams per day PO at nighttime, and that shows a decreased risk of the preeclampsia reoccurring for those women who are at risk.